Hello. In this video, I'm going to start to introduce the concepts of advanced treatment delivery using two techniques. The first is intensity modulated radiotherapy, IMRT, and the other closely related one is volumetric modulated arc therapy, VMAT. These are important delivery techniques because they allow you to conform a dose to a tumor and avoid doses to normal tissue, and I'll explain how that works, introduce the concepts. This first video, I'm going to focus really on about how that delivery is accomplished through a LINAC, and then in the next videos I'll talk about how you design a IMRT or VMAT plan. So here we go. So I think maybe the easiest way to understand this is to start with a case study. So here we're going to look at this prostate plan, and what you want to do here is treat this blue region, the PTV, to a high dose. And then at the same time, you also want to restrict the dose to this region down here, an OAR, organ at risk. This should be at low dose. So that's a challenge. With 3D conformal radiotherapy, what you would do is you put a beam on like this, and there's a beam profile, and it has a relatively even dose across the face surface of the beam. And so it's going to be high dose all the way across, uniform. And then in planning, you put on extra beams here. We've put on 4 beams onto this plan, and so you create this high dose region in orange throughout the whole box here. And you'll notice here that it's covering the high dose is over the OAR. So now you can understand some of the rationale for IMRT in terms of the physical dose distribution. So number one is the coverage of the target. The dose should be conformal dose to the target. That means the dose is tightly wrapped around the target. Number two is it gives you a way to spare normal tissues, to deliver low dose at the same time you're delivering high dose to the target, which is something that's challenging in 3D. And then finally, you can intentionally provide inhomogeneous dose distributions, which is useful for doing boosts during treatment and so on. So let's look now at this region down at the bottom and the sparing that you get and why you can get this with IMRT. In 3D, you have this uniform dose distribution from each beam, and this is very different. In IMRT, it's non-uniform. So here's what an IMRT plan looks like for the same case. And what you'll see here, if you look at this bottom beam, is that we have within a single beam some regions that are very hot, high dose, and some regions that are very cold, like in the middle. It has a cold region. And you can see that you need that cold region in the beam to spare the OAR in this case. So this distribution is uneven within a single beam, and it's called intensity modulation, the modulation of the intensity or the fluence or the dose within a beam. And that's where IMRT gets its name, intensity modulated radiation therapy. So we looked then at this simple cartoon case of a prostate plan. Let's look at another case, a more realistic case, the classic example of where IMRT is used in head and neck cancer. So here's an image. This is from a 3D conformal plan, not IMRT. Now you're trying to treat the disease to different dose levels. So the red disease is gross disease. You want to treat that to 6,800 centigrade, ideally. An intermediate dose region, the blue region, let's say to 6,000 centigrade. And then the green nodal region, you want that to go to 5,000. And you see that with this 3D plan, you don't really accomplish that. You have to stop in order to not overdose the cord. So with this older technique, what you do is stop at 4,500 centigrade and then treat the remainder with electrons and spare the cord. But you can't get an even dose distribution. You can't conform to these high dose regions like you would like to. So with IMRT, here's what you have. You see you have a much better control over the dose. You can conform the high dose regions around where you want to and deliver the dose that you want. And then importantly, you can spare this over here. This is the parotid gland on the left side. You spare that, you preserve salivary function for the patient. That's very important medically. So IMRT has a role in many different disease sites, and here's just a brief summary. So CNS, you can treat a target and then spare normal brain, cord, optic structures. We just talked about head and neck and the sparing you can get there. In the lung, you can spare normal lung, the cord, the heart, the esophagus, brachial plexus. It's also used in breast. In that case, it can provide some sparing of the lung and the heart. Abdomen, you can spare the bowel, liver, stomach, bladder, bone marrow also. We talked a little bit about the prostate, and then also in sarcoma, you can use it to treat the tumor, wrap around the bone, and spare lymphatic drainage system. So these are some of the places where IMRT has a role, and it's basically, it's not a simple technique, and so it took a lot of technology and effort to develop, but that was done for good clinical reasons. It provides benefit to the patients. And it's actually hard to prove that in a randomized trial because those are hard to run, a randomized trial. If you've got two arms where there's not equipoise, in other words, you don't really know the answer which one is better. If there's not equipoise, it becomes unethical to sort of run that trial. And so we don't have level 1 evidence of this. But the dose distributions look so much better that it's justified from that point of view. So now I'm going to talk about delivering IMRT treatments, and first I'm going to have to talk about what intensity modulation means. So let's look at this map. This shows different intensities over the surface of this beam. This is a beam's eye view looking down the beam, and you see some areas are bright, high intensity, and some areas are dark, low intensity. So let me start by making a plot here along one axis just to cross. You'll see it's modulated in both directions, both up and down, and side to side, but I'm going to concentrate on the side to side dimension right now. So I'm plotting here dose versus the distance along this axis. So you start at the left hand side, dose is relatively low, and it kind of climbs up, and then you see here it rises sharply at some point to a high point. So and then it kind of goes down more. So this is one of the key things about IMRT is that you have these sharp dose gradients. You probably are familiar with that word gradient. It means it changes very quickly over distance. That's one of the strong features of IMRT. Now we can also measure such effluence on the beam, and you'll see here a film taken of this exact beam as delivered. And we'll come back to this in our video about QA, but this shows that there's a way to verify the IMRT. So now I'm going to talk about how you would deliver such a complex fluence map. There are a couple different ways to do it. I'm going to walk through one of them first, and then we'll talk about the other ones. So let's say you want to deliver this fluence map. Some regions of high intensity, some regions of low intensity. You'll see that it's only modulated in the one direction. It's not modulated. It's just left-right modulated, not up-down. But what I'm going to describe to you could be applied more generally. So let's start by drawing a line through here, left-right, and then plotting the dose profile like I did in the previous cartoons. So it starts out low and goes high. So the black regions are high dose in this cartoon. Then in the middle it's low, it comes back up and goes back down. So you'll see in the middle there's a low region of dose. That might be, for example, where you're trying to spare the cord in a head and neck treatment from the AP direction, let's say. So now let's look at how you might deliver this on a LINAC. So first I'm going to turn on a beam that irradiates a whole region in the middle here. I'll leave it on for a minute. Okay, and then I'm going to, on the bottom panel down below, I'm going to accumulate dose. So let me put it down here at the bottom, and then I'm going to turn the beam off in the middle. Okay, and now I'm going to move on and make another beam, again in the middle here, just this little strip. Leave it on for a minute, and that will accumulate dose in that region. I put that down below. Okay, and then I move the leaves, MLC leaves, and I irradiate another region over here. I accumulate dose there. I put it on the bottom. I'm accumulating dose on the bottom, and then I'm going to turn on the final region over here. Leave it on for a minute. Maybe this is on a little longer because the dose is relatively high there. Okay, accumulate there. Move the leaves over to the other side and irradiate the other square. Leave it on for however long it needs to be on. And accumulate dose there. And you see now that I have the fluence distribution that I wanted. This method of delivering IMRT is called step and shoot IMRT. I think you can see where it gets its name. It's a relatively simple way of delivering this on a LINAC, but there are other methods as well. Let's look at one of those. I think probably the best way to do that is through a movie. So here you'll see the leaves, and if you look in blue, you see the PTV. The leaves are moving dynamically as the beam is left on, and as they do that, they distribute dose. So you can look at that fluence. So I'm going to turn that on here. So this is a fluence map, and you'll see a region in here that's kind of like a lower dose. I'll watch the leaves as they move across. You'll see it kind of preferentially covers that region. Leaves move out, and then they move pretty quickly over that region. So that gives you that lower dose in that region. Some regions are higher dose. So depending on the speed of the leaves in each region, you can provide intensity modulation as needed. So this particular method of IMRT is called dynamic MLC, DMLC, IMRT, and I think you can see where it gets its name. All right, so there's another form of IMRT that you need to be aware of, and that's called volumetric modulated arc therapy, or VMAT. That's the vendor-neutral term. You'll sometimes hear it called rapid arc. That's a variant trade name, but the generic term is VMAT. It's a different delivery technique, but the goal is the same, to deliver modulated dose. So sometimes it can even be lumped in with IMRT. So to understand that, let's go back and look at a little further how IMRT is delivered. So here you've got 5 beams. And you deliver these beams one by one. So here I'm showing the segments for first beam. Okay, and now I go to the second beam. Now I deliver the segments for that. This is a step and shoot treatment here, one by one. Okay, and then we go to the third beam. Gantry rotates, you deliver. So they're delivered at fixed beam angles, beam by beam. VMAT is different. Okay, VMAT, as the gantry is rotating around, you're modulating the beam. The leaves are moving in a smooth fashion as it goes around the patient. And so it's a dynamic delivery, and the dose rate can change also, and the speed of the gantry, and all that together goes to modulate the dose. So it's a more complex, but the idea is the same. So far, what I've been describing is IMRT as it's delivered on these C-arm gantries that are in common use now, but there are other methods for delivering IMRT, so let's look at those. This is the tomotherapy unit. We looked at this in video 9.2, so you can go back and review that if you like. This is a sort of a donut. The patient slides inside, the unit rotates around and delivers dose as the patient slides through. If you look at the components, you have the LINAC, MLC, the detector, and a beam stop. The MLC is a little different, though, than the MLCs that we've been looking at. It delivers modulated dose by opening and closing, like this. So it's either open or close. This is called the binary MLC. It opens very quickly, delivers modulated dose in a slice. Another method to deliver IMRT is to use compensators. I'll describe what those are. This isn't widely used right now, but I think you need to understand it. So to motivate this, let's look at this. The MLC as it slides across, and let's look at this point, the X, inside the PTV. Watch how the leaves move. And you'll see that for most of the treatment, that particular point is covered. And that's true of actually every point in the PTV. And so the result is that the MLC is not very efficient at delivering dose. It's quote-unquote off for most of the treatment. So that's one motivation for using compensators. So let's look at how those work. Compensators are basically pieces of metal that you put into the beam to attenuate dose where you want to attenuate it. Here's one from a commercial vendor. Let's look at how these work. So go back to this picture. We want to deliver this particular fluence profile. Let me draw a source here and a beam coming out. And here you put the compensator up near the head of the machine. And the thickness in the center will be very thick. That delivers the low dose in the center. And thinner on the edge here, and then thinnest on the outer edge. Okay, this whole thing is filled with metal. So typically it's brass or maybe tungsten, and that delivers the attenuated dose that you want. So a beam ray going through the middle will be attenuated a lot because of the thickness, less in the outer edges, and so on. And that will, you can design the compensator to deliver whatever fluence map you want. Of course, this is a three-dimensional object. You can modulate in both dimensions, and it has a very high resolution compared to MLC. So let's look at these different regions. And what if you see here is if you draw the profile of the compensator, the thickness is kind of like the mirror image of the fluence map, although you have to correct for some other effects like scatter and so on that are in the compensator. But basic thing is that the compensator is always on, quote unquote. At any point under it, it's delivering the dose rate, dose per unit time that you want it to deliver. And so it's a very efficient way of delivering dose. So compensators were widely used in the late 1990s when IMRT was being developed. They've sort of fallen by the wayside as MLCs have taken over. But there are some real advantages to using compensators in terms of efficiency and so on, but they were never fully optimized in their design. By way of full disclosure, I actually have a project using compensator-based IMRT where we have an NCI-funded grant to look at the development of this type of IMRT as a very efficient, low-cost way of delivering IMRT for the setting of low and middle-income countries. And it's a very interesting new application of what some people think of as an older technology. All right, so those are the basics of how an IMRT or VMAT plan is delivered on a LINAC. I'm going to leave you with a little bit of further reading. There's quite a vast literature in this area, so obviously this is not everything. In the next video, I'm going to talk about how you design such a plan. So how do you figure out where all these leaves should be in order to give you the correct dose distribution? All right, thank you.